All right, can you hear me okay? All right, thank you again to the organizers and to Dr. Dev for including me in this opportunity to join you guys for this meeting. So these are my disclosures, and this is my other disclosure, why I'm with a cane. And that was on January 8th, so I'm happy to be here now with just a cane. So my objectives today is just to briefly review, and again, my goals are going to be to talk about when to suspect amyloid, and then the keys to diagnosing light chain and TTR amyloid. Again, I had this slide forever, and I've been doing amyloid talks since 2014, but I love Jabba the Hutt because Virchow described this is what the iodinated staining looks like in 1884. Amyloid means starch in Greek, and he called it lardaceous and amorphous deposits in the heart. And again, these are protein misfolding disorders, and there's numerous causes of amyloidosis, but we're going to be focusing on the two most common. And again, it's these, when a protein dissociates and these fibrils become insoluble and deposit in the tissues. Again, what every practitioner really needs to be aware is 95% of amyloid affects the heart. And again, as Dr. Dave was talking about, this is a systemic disease, but I find that it's cardiologists that are often reaching out to neurology, hematology, and we're the ones that are the ones recognizing this. What everybody needs to know is the two of the most common that we're going to be talking about is light chain, which I can see if I can get my pointer to work. I'm not sure if I can. Well, anyway, the things that look like olives are plasma cells. And this is a plasma cell dyscrasia where a clone of plasma cells in the bone marrow are producing these cardiotoxic proteins or light chains. And that is, although not as common as TTR, is very important to diagnose. Transthyretin is liver is the production, and a lot of people don't know, but we'll talk about is TTR can either be wild type, which means there's no mutation in the gene, or hereditary, where there's a variant that causes this protein to misfold. And again, I think my colleagues are going to be talking about this. I've always had this slide to emphasize to my primary care and to my cardiologists that how critical it is for them to make sure that they follow these algorithms that we're going to be reviewing. And because of especially the nature of AL, which is really what got me passionate about this in 2012 when I had a young 42-year-old dying of light chain and trying to navigate getting him the care he needed. And because we have new chemotherapies and stem cell, it's really important that we reach out and get this diagnosed early. One of our colleagues is going to be talking about MGUS, but I always needed something to dumb it down for me because I'm often actually arguing with my hematologist that I want the heart biopsy because they often just want to stop at a bone marrow biopsy. And again, because they often mislabel my patients as MGUS when they really have light chain amyloid. So it'll be important to, as a cardiologist, sometimes you have to go to bat. So transthyretin amyloid. TTR transports thyroxine, retinol, TTR. The amazing thing is we don't really have to depend on it. Only 10% of our thyroid transportation is from thyroxine. Vitamin A, because it's so fat-bound, we can actually, as we'll be talking about in treatments, we can get by without TTR. I also remind people that it's pre-albumin. The reason it is on old days when we used to do something called electrophoresis, it's the protein just before albumin. But it's amazing that we never knew, but we could actually measure TTR stabilized levels in our routine pre-albumin thing. So as we're going to talk about, I can't quite see my slides, we're going to talk about the pathology. And again, this is a nice cartoon from the guidelines that talks about how this tetramer of TTR can dissociate, and that's what forms these fibrils that start accumulating, these insoluble fibrils in the tissues that leads to the pathology. This is an old slide I have, but I think it's important to think about the phenotype, and this gets a little bit into how to apply the guidelines, that you have to decide, what about my patient? Am I going to do the rule out light chain? We're going to go through that algorithm that everybody should be aware of. I'm at the VA. My biggest population is I deal with about 40% African American, so I see a lot of hereditary TTR, which is common because of this mutation present in 3.5% of blacks. I haven't seen as many other variants, but it's very aware. And again, the common thing we're going to see is older men and this is that wild-type phenotype. This is from the new guidelines, which really the emphasis to our colleagues. Let me see if I can get my pointer to work. Anyway, does that work? Anyway, the main thing is to make sure that people are aware. As a cardiologist, I'm the one making the referrals to neurology and hematology, is that the extra cardiac manifestations, and those are the clues to suspecting amyloidosis. We're familiar with the cardiac manifestations, but often we miss the carpal tunnel. When we did our assay, even though I found that probably most of my patients, if I questioned them, they had carpal tunnel symptoms, but they hadn't been diagnosed. The spinal stenosis is due to TTR, in this case, because of deposits in the ligamentum flavum that causes spinal stenosis. We see the neuropathy. And autonomic dysfunction is often written off as just orthostasis due to medications, but the intolerance of cardiac medications is really a clue, or the hypotension. And I do orthostatics as part of my routine physical on every patient. What I want to make sure people are aware of this slide is that we are talking about systemic, we're talking about amyloidosis, and proteinuria. It's very important to pay attention. So I often order spot urine with everybody to look for nephrotic range, because that's really a big concern for light chain. And again, this is something that I think has already been underscored, and we're hoping in these gatherings with this interest that we're getting people to not do this, where we have patients going to 3 different doctors and the diagnosis missed for 1 or 2 years when they really could have been on treatment much earlier. So, what are the keys to diagnosis? Step 1, suspect it. Step 2, we're going to screen for light chain. Step 3, we're going to do scintigraphy for TTR. Those are the things you're going to go home with today. This is the new algorithm, which I will say the graphics are not as good as the old algorithm, but I figured I better bring the 2023 guidelines. We're going to start with step 1. What are the clues? And again, this really hasn't changed, but this is from the current guidelines. And again, I want to underscore on the right all the extra cardiac manifestations, the carpal tunnel, the spinal stenosis, hip or knee surgery. How many people do we know with that? Again, not specific, but again, clues. The neuropathy. A lot of people aren't aware, especially in the autonomic, how GI symptoms, either due to either gastroparesis or often misdiagnosed or ignored, and urinary symptoms. On the cardiac, one thing I did add that they didn't put in the guidelines is this aortic stenosis, which I'm going to discuss, that we see this low-flow severe aortic stenosis. Then what I'm going to be going through is the EKG and echo criteria to have for that step number 1 is suspicion, suspicion, suspicion. So one of the things we were talking about, a lot of people say, well, if the EF is reduced, it can't be amyloid. That's not true. So it's just important in heart failure. And the reason is a lot of times my patients may manifest when they develop new AFib or heart block, and the EFs are often reduced in that setting. So I try to say, don't worry about the EF, focus on the other issues. The other clinical things is often the AFib may not be fast, despite them being on no rate control drugs. Why would a 70-year-old have a heart rate of 70 or 60 in AFib? It should be higher. It tells you there's AV nodal disease. They're not tolerating their heart failure medicines. Of course, you'll hear me talk about GDMT, because I find my colleagues are all just focused on GDMT, but they never ask, why does this patient hurt? So I call it goddamn medical therapy, because they're not doing the diagnosis, and they're going like, oh, well, let's just take the carvedilol off and put them on metoprolol so we can try the Entresto again. And then, it's like, no, the blood pressure's 75. Let's think about why the blood pressure's 75 rather than keep messing around. So GDMT, think about maybe it's amyloid, and this is why the patient's not tolerating it. Again, this is from the Unveil trial that I added the notation. Think about aortic stenosis, especially low-flow severe AS. Doesn't mean don't do the TAVR, but it's important to think about it. In this one study with Matt Maurer and colleagues, they looked at the prevalence by scintigraphy of TTR amyloid in patients undergoing TAVR, and it was 16% of the population had at least level 1, 2, or 3 of TTR evidence on that scan. So I personally wonder if we shouldn't be scanning everybody going for a TAVR, especially if their wall thickness is above 1.2. My last one I add here is not in the guidelines, but this is my little pet peeve, is I've had a couple patients present with stroke that later came out to be amyloid. And often if I have a patient with LA thrombus, especially if they've been on anticoagulation, think of amyloid because it's a prothrombotic state, both light chain and TTR. So what are the clues on EKG? And then most of you guys are already educated enough. I grew up in the era where they said you had to have low voltage. Bottom line, TTR, only 10% have low voltage, maybe 30% of light chain. It's the absence of LVH, or the absence of high voltage in somebody with a thick heart. The other thing is the pseudo-infarct pattern. You'll see what looks like an inferior MI, anterolateral, anteroseptal. Again, in the absence of wall motion abnormality or evidence of scar, think amyloid. Why is there a pseudo-infarct pattern? Conduction problems, AV nodal, bundle. This is one of my patients who, again, very typical, doesn't have high voltage, but his wall thickness is 1.6. So why does he have this pattern? There's no perfusion abnormalities. He has normal coronaries. But what does he have? He got inferior Q waves, anterolateral Q waves, and the absence of LVH. So, echo, this is my pet peeve. So the criteria are the bar to suspect is very low. Thickness of 1.2. Normal is 7 millimeters to 11. You should be thinking, and this is a big deal because I grew up in an era where we ignored everybody until the wall thickness got to 1.6. No more. Everybody was written off as hypertensive heart disease. So what we're going to talk about is whether you're a cardiologist or not, reading the report, don't trust your readers, and sometimes I don't trust my sonographers. I probably remeasure the heart 40% of the time. Look at the measurements. I'm going to show you how to look at a report. If your lab isn't reporting relative wall thickness, start doing it and have it auto-calculated. And we're going to talk about the role of this, getting this relative wall thickness score and show you how we calculate that. Biatrial dilation, not specific. It helps me if I have somebody who's got a thick heart and the left atrium's normal and they don't have diastolic dysfunction. I go like, maybe it's something else. But most of these people are going to have left atrial enlargement, diastolic dysfunction. And then we're going to talk a little bit of tissue Doppler. I call it the 5-5-5 rule, and I'll just show you a picture of that. Again, how to look at the report. And again, because I'm an echo person, I always look at my own images. I can tell first thing I ask is who read it. Never mind, I'll read it myself. So we all have that bias. And then we'll talk about strain imaging. Okay, so I don't know if my pointer's going to work. For the non-echo people, the heart should shorten in systole. So it's about 20% shortening between if you take two spots. The normal is that red bullseye. Oh, good, it is working. This is one of my amyloid patients where we can see the strain is completely abnormal in the base and the midwall, but the apex is preserved. And I've gotten to where you can almost see it when you look at the echo. The apex is contracting and the base is not. This is one of my patients who just recently had an echo. Very typical, the very thick. Notice how it's not necessarily thick everywhere. The septum often is more thick. He has grade 3 diastolic dysfunction. And this, for the non-echo people, this is the tissue Doppler signal. And one of my clues is what's called the S prime. What it is in systole, the annulus should be pulling down to the apex. It should be at least a 10 millimeter displacement. So I look at my report. So if somebody's got a normal EF and the S prime is down, this is discordant. There's something wrong. And then finally, this is our strain imaging, which it should be about -20, -18. So one of the things we report routinely is the global longitudinal strain. And our guidelines, if it's less than -15, we should be suspecting amyloid. So look at your report. I actually look at the report before I read the echo. And it's one of the new habits I've developed. And notice this patient, 1.66. He'd been written off as hypertrophic or hypertensive heart disease. This is the relative wall thickness, 0.76. Normal is less than 0.42. So we have it in all of our reports and trying to train my readers to bring that out. And down here is the tissue Doppler, and you'll see that the S prime is only 4.9. Clues. So I always start by reading the numbers, and then I look at the images, and I make sure my numbers are accurate. And this is just a typical patient that you shouldn't even have to look at the echo because there's a gentleman that probably had so many echoes before he was diagnosed. 74 black gentleman, he'd been labeled as NSTEMI, he even had AFib, he was having hypotension, he was needing mitadrine, he had carpal tunnel, he had spinal stenosis. I mean, other than having, TTR, tattooed on his forehead, he had just about everything. And again, his echo showed a high thickness. And again, bottom line, he actually ended up needing a biopsy because he had MGUS, and we confirmed TTR. So for my sonographers, I always say make sure your measurements are accurate. For my readers, report the wall thickness, look at it, and make a conscious effort. It should be as important as the ejection fraction. And for my ordering providers, read the report, look at the numbers, don't rely on your interpreter to tell you what to suspect. Our job is to suspect. And this is from the European guidelines. They say if you have a septal thickness of 1.2 and any of these things, suspect it. And these are people that think about screening. So, and then this is the Davies score that I was talking about from the Mayo Clinic, from Margaret Redfield and Martha Grogan's team, where they came to this score, which helps a clinical score to help us suspect. And again, this is especially powerful for wild-type amyloid, where aging, just being old, is a risk factor, and it's something that Sandesh was talking about. Do we screen all 90-year-olds? So the lab clues, oops, I missed that. Sorry about that, but the basing of when it is score, I don't know how to go back, here we go, is to look for the light, for troponins. Still, even a month ago, I had one of a new amyloid patient. They labeled him as NSTEMI, took him for a cath, and again, he had persistent troponins. We order outpatient troponins, make sure your lab can enable that. And then I also have in our lab an NT-proBNP. It's disproportionately higher in amyloid patients, and the ratio, instead of being 4-to-1, is often 10 or 20-to-1 with my BNP. And so now, step 2, look for light chain amyloid. Now we're going to talk about this, but the bottom line is you should order this lab. And if your lab, we have a whole amyloid order set, make sure your lab has a clear order set. And again, it has to be immunofixation. At the VA, it says SPEP, but everyone goes to Tucson. All of our lab samples go to Tucson where they do immunofixation of the urine and the protein. The reason is SPEP is not sensitive enough. You have to do immunofixation. And then you need to do quantitative kappa and lambda light chains. So all 3 must be ordered and done. Okay, and then what you're trying to do is find out, is there a monoclonal gammopathy? If there is, then you have to work with your hematologist to figure out what it is. And then if any of these 3 are, you have to work with your hematologist. Like I said, sometimes I have to tell my hematologist I want the cardiac biopsy because they often say, no, it's fine. The bone marrow is fine. You cannot diagnose tissue from the bone marrow necessarily, okay? So this is, we're going to be talking about the workup of the monoclonal gammopathy in another talk coming up here. But now the next thing is step 3. So number 1, suspect. Number 2, screen for light chain. Number 3, spec for scintigraphy. And I keep emphasizing spec, but my colleague Dr. Shaw is going to be talking a lot about that importance. So you need to see grade 2 or 3 uptake. I tend to follow the older algorithm, so I'm being nice, and I brought up the 2023 guidelines. I tend to order, depending on my phenotype, both the scintigraphy and the light chains, because if I've got an 85-year-old Caucasian veteran with heart failure, I'm expecting TTR. It takes sometimes a week to get the light chain stuff, so I order both at the same time. And this is where they have this little Michelle Kittleson, where they say, it's okay to do both at the same time, but if I had a 45-year-old female with new heart failure and a thick heart, I'm going to start with the light chains. So this is the scintigraphy, which Nishan's going to talk more about how we learned that these phosphonate tracers bind to the heart, bind to TTR more commonly. And this was the paper that kind of led to us identifying what became the non-biopsy diagnosis. And Nishan's going to talk more about these things. So in summary, you should order the scintigraphy in anybody you suspect. Again, I order it simultaneously, or you can order it after you've done your light chain. So again, and again, the final thing is when you need biopsy, and we're going to talk about that in another talk, but if you have positive gammopathy or at all, you're going to need a biopsy. So I'm not going to talk about genetic testing, but once you confirm TTR by biopsy or non-biopsy, then we'll do the genetic testing. So in summary, these are remember the clinical clues to this. Don't forget about the echo clues, and again, the biomarkers. And again, the first thing is to always suspect, and make sure you do the step 1, 2, 3, suspect, screen for AL, and do scintigraphy. And thank you for your attention.